Hello, welcome to 12 lead part 2, where we're going to talk about what are we looking for on our 12 lead. Let's start with talking about kind of the parameters and the different things that show up and why. And first is ischemia. So we know that ischemia is lack of oxygenation to the heart's tissues, and it can show up as ST depression or T-wave inversion, and that's one of the things that we are going to look for. It may also show up with peaked T-waves or other changes to the T-wave morphology. It may or may not progress to injury or infarct. Sometimes ischemia is simply that. It may be a case of angina or something else that's causing some ischemia that's only temporary, but it may be an indication of early signs of an infarct. We want to look for injury patterns. Random changes to ST or T waves in different parts of the 12 lead are not meaningful, but when they show up in areas, anatomical regions that are consistent with a particular coronary artery, then that's likely related to some degree of blockage of that coronary artery. Ischemia then can progress on to injury if that lack of blood flow continues. Injury is our clue that cells are actually being damaged. Prolonged ischemia start to damage those cells, and we start to see ST elevation. Again, we're looking for it in patterns. Regional patterns, which I'll talk about in another video, to show up and help us to determine where the infarct is occurring and what vessels are likely occluded. And if this isn't corrected quickly, this is likely to progress on to actually infarcted tissues. In infarct, we're going to see some other changes. We may or may not see a development of a Q wave. So infarct is the actual death of the tissue. So now cardiac tissues are dying. This is not reversible. We may be able to salvage other tissues in the vicinity, but the tissues that have died are going to stay that way. They may or may not show up with a pathological Q wave, and I'll talk about those in a minute. ST elevation may be present or absent depending on when the infarct occurred, and keep in mind that a fair percentage of MIs, acute MIs, do not show ST elevation evidence on a 12 lead. It's quite possible to have infarcted tissue and ongoing injury at the same time, and I'll talk about that in a minute as well. In other words, you may see Q waves and ST elevation together because there's more than one thing going on, or the thing that's going on has been going on for a long time. Again, we want to look for these findings in injury patterns. We're looking for 2 or more contiguous leads, meaning 2 leads that look at roughly the same part of the heart. Quick terminology review. When we talk about a Q wave, it's that first negative deflection from the baseline in front of the R wave. Now, this can be either physiologic, meaning it's a normally occurring event, and many patients will have Q waves in multiple leads, and they're normal. That's not an abnormal finding. It is not an indication of infarct. They tend to be narrow. They tend to be small. So they tend to be less than 1 box in width, 0.04 seconds. And with that small width, they also tend to not be very deep. Pathologic Q waves, on the other hand, our diagnostic criteria for that is if that Q wave is wider than 1 small box, if it's wider than 0.04 seconds, then we consider it a pathologic Q wave. And if it shows up in one of those injury patterns, it could be indicative of a prior infarct. Those pathologic Q waves are often deep as well. With that added width often comes more depth, which also makes them more pronounced and easier to spot. Pathologic Q waves, like in the examples at the bottom of the screen, are wide and often deep that start the QRS complex, and we're looking for those in contiguous leads, indicating that's evidence of a blockage or an infarct corresponding to a specific anatomical region of the heart. Isolated Q waves are usually insignificant. In other words, if you see one or even more than one, but they're not contiguous, it may be a random electrical event and it is not considered diagnostic. We look for Q waves in contiguous leads, as I just said, and we should also recognize that not all infarctions will produce Q waves. Back to our terminology, the R wave is that first positive deflection. It includes the upward stroke as well as the downward stroke returning to the baseline. And our S wave is the negative deflection that follows the R wave. The S wave includes departure from and return to the baseline. As I've talked about in other videos, we call the entire complex a QRS, even if it doesn't have a Q wave, even if it doesn't have an S wave. Any combination of those directions, the entire complex is referred to as a QRS complex. The J point is important Because in order to determine where the ST segment is, we have to determine where it starts. And the ST segment starts at the J point, which is where we believe the QRS complex ends and the ST segment begins. Oftentimes, like in this machine-generated image, it's a very obvious angle, change of direction, which makes it easy to see. On real patients, on real ECGs, it's sometimes much more challenging to decide where you think the QRS ends and the ST segment starts. We look at the ST segment. We don't really care how long it is. That's really not relevant to this discussion, but we do care about how it is positioned in relation to the baseline. Again, in this computer-generated image, the baseline is perfectly straight, and it would be easy to spot if it is above or below that line. In ECGs coming from real patients, there are physiologic changes and abnormalities that may make that a little more challenging. Typically, you want to compare that ST elevation to the next section following the T wave, which we call the TP section. If you have a clear baseline there, that's a more reliable comparison than looking at the PR section, that little segment right between the P wave and the QRS, because it is often skewed by a variety of things, including different atrial morphologies, different changes in AV node activity. And so the ST compared to the TP is a more reliable way to determine if that ST segment is elevated or depressed. Here's a few examples. The first example is a J point that's easy to spot and is at the baseline. The ST segment has no elevation or depression. The next two examples both show ST elevation. The first one, there's a clear change in direction from the QRS to the ST. And in this third example, labeled C, you notice that it's kind of a curving line that's not a real clear change of direction. And in those cases, you give it your best guess as to where you think one complex stops and the next one starts. Example D is a clear example of ST depression with a J point all the way well, it looks like at least 2 millimeters below the baseline. And example E is showing a J wave. And this is kind of an unusual form that comes up in a variety, sometimes because of medications, a few other things that I talk about in a later video. And again, we give it our best guess as to what we're going to call the J point in those somewhat unusual situations. Most of the time, a J wave, an Osborne wave, different names that are given to that configuration you see under E, most of the times those are not associated with an ST elevation MI, but rather something else. An acute myocardial infarction is an evolving event. And what we mean by that is that it's a blockage of an artery which leads to ischemia, which then leads to injury, that leads to infarct. And oftentimes we can see the evidence in our 12 lead of that evolution. We mentioned this a little before, but I'll go over it again. So the first thing that might show up are tall T waves. You can see peaked T waves can be suggestive of an AMI. They might show up even before clinical symptoms. They're only going to show up in the leads that are looking at the area that is potentially going to infarct, and it's a clue. It is not a diagnostic finding, but it may be an early indication of ischemia moving towards an infarct. Acute changes show up with ST elevation, as we already mentioned. This implies that there is myocardial injury occurring right now. That elevated ST segment is presumed to be acute rather than any old cardiac event or old cardiac damage. As an infarct continues, if it goes untreated and unresolved, this ST segment is elevated and a Q wave may start to form. As we said before, not all infarcts result in a Q wave, but if one is going to form, it can form in this time period, but this typically takes hours of infarcting tissue before that Q wave is going to show up. The ST segment elevation that you see in this example is a clue that the infarction is still ongoing, and it has progressed to the point that right now we're looking at a patient that has both infarcted tissue and ongoing injury. Hours to days later, we may see some changes. That ST segment may go back to normal, back to baseline. The Q wave remains wide or deep, and the T wave may be inverted or odd in appearance. And then weeks later, The ST segment is normal, the T wave returns to normal, but that Q wave remains. That Q wave is sort of permanent souvenir of the infarct that occurred, and this is how we are often able to diagnose someone as having had a silent MI, meaning they've had an infarct in the past that they didn't know they had because they didn't have any specific signs or symptoms associated with it, but this evidence in contiguous leads on the 12 lead shows that an infarct has occurred. This slide just captures the progression that I just went through in one single view. If you want to pause, you can look at that. And when we talk about AMI recognition and the criteria we need to use on our 12 lead to make that diagnosis, there's some variation for around the country in different areas, different cath centers, different EMS protocols. But what I'm going to lay out here is a pretty common set of criteria that's used to make this determination. The first is that you have to have ST elevation greater than 1 millimeter, so one little box, in 2 contiguous lateral or inferior leads. Those are the leads that are listed here. Or greater than 2 millimeters of ST elevation in 2 of your anterior chest leads. So that's V1, V2, and V3. And the reason for this, and maybe a way to help remember which ones need that added evidence, is that V1, V2, and V3 that are right on the front of the chest, essentially sitting on your sternum, are very, very close to the heart. And minor, insignificant electrophysiologic changes in the heart may show up as ST elevation in those leads because they're so close to the heart, even when there is no actual infarct in progress. That's why we're required to see greater than or equal to 2 millimeters of elevation in those leads before we can consider that a diagnostic finding. And finally, many of our cardiac machines, especially the monitor defibrillators being used in the field today, have machine diagnostics built into them. They do an interpretation. They give you a printout. And if the machine tells you that your patient is having a STEMI, in many systems that's enough criteria by itself to be a straight trip to the cath lab, to be a cath lab activation. In some systems, however, that's not alone sufficient because the machines are not foolproof and there is a margin of error. So my advice, which I'll repeat in a later video, is trust but verify. Take advantage of the machine's ability to spot something that you may not, but look for yourself and verify that those findings are consistent with your interpretation as well. What about bundle branch blocks? One of the criteria that are often included on that list that I just did is a new onset of a bundle branch block. Well, if you have a patient who's never had a bundle branch block in the past, and they're having one today, and they're having cardiac symptoms, the most likely explanation is they're having an acute MI that has damaged their ability to conduct electricity through that bundle. However, it is also very difficult in the field to know what is new and what is old. If we have a mechanism, if we have the ability to know for sure that this is new, this is a strong indicator of a possible MI. But it's also responsible for a lot of false activations in systems where every bundle branch block goes to the cath lab, because we have a lot of patients walking around with bundle branch blocks that they may or may not be aware that they've had for some time, and not because of any acute event that would benefit from a trip to the cath lab. So I mentioned ST depression before. And obviously we talked about ischemia. I want to mention a couple other things that can cause ST depression. One is any abnormal conduction pattern. So an intraventricular conduction defect, such as you would get with a bundle branch block, left ventricular hypertrophy, a fast supraventricular tachycardia, a pacemaker rhythm, any of those can produce odd-looking, odd-shaped, wide, abnormal QRSs. And just about any time you have an odd, funky, ugly-looking QRS, it is likely to result in changes to the repolarization stage, meaning you may see changes in the ST segment or the T wave. And we have to be careful about attaching significance to those ST changes because they may not be a reflection of anything significant other than a reflection of an abnormal conduction pattern. And the third category is reciprocal changes. And this is particularly relevant when we're diagnosing a STEMI. If you think about 12 lead as a camera, You're going to picture your camera, or you're going to position your camera rather, on one side of the heart in order to view damage. On the side that I am viewing, in this case, we have an infarcted area. And if I look at my lead from this side of the heart, I'm going to see positive changes because the electricity is moving towards that side of the heart. The ST segment changes are going to show up in that lead view. I see evidence of an MI. If I look at a camera view from the opposite side of the heart, I am now likely to see the opposite. So what I'm seeing is not an evidence of ischemia or something else going on that side of the heart. It's actually seeing a reverse view of the big infarct that's happening on the opposite side of the heart. Those reciprocal changes do not show up, it's not one specific lead is reciprocal to another, but in general, the inferior leads, 2, 3, and AVF, look from one general direction at the heart, and the rest of the leads, 1, AVL, and all of the chest leads, tend to look from a higher view. And so if you're going to see reciprocal changes, an infarct in that inferior portion is likely to show up with reciprocal depression in the opposite, or vice versa. We'll talk about that more in a subsequent 12 lead. We'll look at specific examples of what that looks like and how it marches out. And we'll talk about localizing our findings. I want us to really focus on where on the 12 lead you look and how that helps us to identify which coronary arteries might be impacted.